Good evening, everyone. How are you all? So again, welcome to our First Aid AMC Clinical free 2-week session. This is going to be your last session of this free 2 weeks classes. And I hope that you guys enjoyed our free 2-week session so far. You have learned quite a few topics which are quite important for your exam. We discussed a few about psychiatry. We discussed a medicine topic, which is your cardiology. We did a role play on that. And also today we are going to go through a bit of pediatrics. So I have tried my best to give you an idea how this course is going to be, how the classes are going to like, so that you know what, like for the next 5 months, what's going to happen. And I know that most of you who are here, you already is a part of our course. And just to remind you that this 2 weeks free session will be ended today. And then our course will be running smoothly from 27th. So 27th will be your orientation class. And then definitely we will just move on faster to finish this course as soon as possible within the next 4 months. So today we are going to focus on a pediatrics cluster, which is super important for exam. A lot of questions come from here. So that will be pediatrics vomiting cluster. So let's start. And then at the end of our today's session, we will go through a little bit about the course details. And also you can ask any questions if you want about the course at the end. Okay. So let's start with pediatrics vomiting. So just like any cluster, we always start with a differential diagnosis of that cluster. And then we have a format of history and physical examination of that cluster. And then we do the cages. So if a child presents to us with a vomiting, what will be our differential diagnosis? First, it could be gastrointestinal causes or it could be non-GI causes. So gastrointestinal causes could be gastroesophageal reflux, could be pyloric stenosis, duodenal atresia, ileal atresia, jejunal atresia, incarcerated or obstructed hernia, could be intussusception, volvulus intestinal obstruction, Hirschsprung disease, esophageal atresia or tracheoesophageal fistula. A lot of questions come from these GI causes. If we go for non-GI causes, then we have got urinary tract infection. So any kind of infection can cause vomiting in a child. So UTI, testicular torsion, ear infection, even if it is a meningitis or septicemia, child can present with a vomiting. Same with lung or chest infections such as pneumonia. So these are the main differential diagnoses that you want to rule out in a vomiting child. Among all these differential diagnoses, the cases that come in exam are gastroesophageal reflux, pyloric stenosis comes in exam, duodenal atresia comes in exam, hernia comes in exam, intussusception comes in exam, intestinal obstruction comes in exam, gastro comes in exam, this one also comes in exam. So all these 8 cases, it comes in exam. So you can understand the importance of this cluster, right? And using just one single format, you're going to finish 8 cases without even remembering the history and physical examination of these cases. So all you need to know is just one format and you'll be able to finish at least 8 to 9 cases, which comes from vomiting in a child. From non-GI causes, only the UTI comes in exam, but others, I have seen testicular torsion to come in exam, and others not too much. Septicemia comes in exam, but it comes with fever and child gets drowsy with rash. So let's start our format. So let's say, so this is the first time you're doing our pediatric class, right? So pediatrics has a different kind of approach than the other cages. In pediatrics, there will be the parents who you are going to talk to, not the child. So there will never be a child in the exam as a role player. So one of the parents, either the father or the mother, will be there who is going to talk. Excuse me. So who is going to talk about the child? Okay. So let's say a child coming to you with a acute vomiting. So how we are going to approach that case? So we'll start with, let's say Jenny is the mother who is here and Sam is the child. So you will say like, hi Jenny, this is Dr. Arshan, one of the doctor in this emergency department. Nice to meet you and Sam. I understand from the note that Sam has been vomiting since the morning. Is that so? Yes, doctor. He has been vomiting since the morning. He's not able to keep up anything. You'll say that I'm very sorry to hear that. It must be quite stressful for you. But now that you are here, we will take care of your Sam. So, and also because he has been vomiting a lot since the morning, I want to make sure that he is vitally stable and he's not severely dehydrated. Now, Jenny, would you tell me a little bit more about these vomiting episodes that he has got? So that will be your initial approach in this case. See that how it is a bit changed from the other cases that we have done. So after that, Jenny will give you some idea like what's been happening and you need to find out the rest of it from her. So you want to know since when it started, how many episodes so far, is it for the first time? We always ask CCVO in any kind of discharge. Vomiting, also kind of a discharge that's coming out of the body. So C means colors, another C for consistency, V for volume, and O for order. So ask the parent that, what's the color of the vomitus? Have you noticed any blood in it? Is it runny or thick in consistency? Or you can also say, what is the content of the vomitus? That means what have you seen in the vomitus? So runny and thick doesn't matter that much for vomiting. So don't bother asking that. But you can ask this question, what was the content of the vomitus? Like is it the breast milk or even any food that you have given? So we want to know that. Is it small or large in amount? And is it very foul smelling? Then ask these three questions. Is it very forceful or projectile in nature? Forceful projectile vomiting indicates pyloric stenosis. But that doesn't mean that every time there is a projectile vomiting, it will be pyloric stenosis. Even a gastroesophageal reflux child can have a projectile vomiting. So don't just give your diagnosis based on a single finding. But projectile forceful vomiting usually relate to pyloric stenosis child. Any relationship of the vomiting with the food? And if yes, then how long after feeding does he vomit? And does he get hungry immediately after feeding? So children who develops pyloric stenosis, because their pylorus or the end of the stomach is narrowed, anything the parents give to the child that cannot go to the small intestine. So it comes out immediately after feeding. So even though the parent is breastfeeding or giving some food, because everything is coming out, child gets immediately hungry even after feeding. So that's what we try to find out. So is it forceful projectile, any relationship of the vomiting with food or feeding? If yes, how long after feeding? And does he immediately cry after feeding? Or does he get hungry immediately after feeding? Okay, so that's your vomiting question. Then along with the vomiting, we ask about associated symptom. Now, it's not mandatory to ask associated symptom. You can jump to differential diagnosis also. Totally fine. Nothing to be worried on that part. But if you want to ask associated symptom with vomiting, then you can ask about any distension of the tummy, any lump or bump in the tummy or in the groin. But as I said that we will ask these questions in the differential diagnosis anyway, so you can just jump to DD. That's really okay. I always ask in the differential diagnosis of vomiting, I ask about bowel and bladder first. So ask about the bowel habit. That will give you intestinal obstruction differential diagnosis. So ask about how about his bowel habit. When was the last time he opened his bowel? Any history of diarrhea or constipation. So if there is a history of diarrhea with vomiting, you can think of gastroenteritis. If there is a history of constipation, like the child did not open bowel for 3 days or 4 days, and now there is a tummy distension, and also child is vomiting, then you would be concerned about the intestinal obstruction. Okay, so try to relate these questions to different differential diagnoses. So in bowel habit, you can definitely ask this question. Have you noticed any swelling or any distension of his tummy? So you have done with the bowel habit. Then you go to the water works or urinary works. So for UTI, we can ask, how about his water works? Have you noticed any change in number of wet nappies? Any change in color or smell of the urine? And does he cry while passing urine? Now in here, we ask two questions. One is any sign of dehydration and also definitely UTI. So depends on the age of the child. For a 10-year-old child, you will not ask about wet nappies, right? But for a 1-year-old, yes, you are going to ask about number of wet nappies. So it totally differs based on the age of the child, what type of question you are asking. So how about his water works? Any change in number of wet nappies? So children who gets dehydrated, their urinary output will be less, and then the parents can say that number of wet nappies has got reduced. So this is a sign of dehydration. And for UTI, sometimes parents can say that the urine smell bit funny or child cry while passing urine. So these are the sign of a likelihood of a urinary tract infection. Okay, so ask about bowel and bladder. Then go for other differential diagnosis. So for intussusception, we ask, does he draw up his legs while crying? Does he turn pale while crying? Now, it's not a bad idea to ask a bit more about intussusception. So intussusception, it's kind of an intestinal obstruction, but in here there will be like the two guts will be blocked, or there will be telescoping of one bowel into another bowel. Now, what happens is that in intussusception, children will have a episodic screaming episode because they will be in a lot of pain and they will scream because of pain. And when they scream, they are in so much pain that they draw up their leg up to the chest. And it's not a constant thing, it comes and goes. And during these episodes, they also become pale. So for intussusception, you can ask that, have you noticed that he is getting intermittent screaming episodes? Does he draw up his legs while crying? And does he turn pale or blue during crying? So that will be intussusception question. And then you can ask about some other non-GIT causes. Before going to non-GIT causes, we also ask about incarcerated or obstructed hernia. So that's why this question is here. Have you noticed any lump or bump in his tummy or especially in the groin? So if there is any lump on the groin, then we would be thinking about a hernia. Okay, so that's the main 4 differential diagnoses that you can ask. If we go back to the differential diagnosis, you can see that for gastroesophageal reflux, there is no specific question. It's mainly about vomiting. For pyloric stenosis, we already asked questions regarding that. Duodenal atresia, mainly child comes with vomiting immediately after delivery. So within 24 hours of delivery, there will be vomiting. So that's, again, there is not much of a question you can ask. Hernia, we are asking about any lump or bump on the groin. We are asking intussusception question, intestinal obstruction question, gastro question. For esophageal atresia, again, child will have vomiting within like 24 hours of delivery, but nothing to be asked in here. Now, non-GI, we asked UTI question. For children who has torsion of testes, they will come to you with a pain in their testes. Okay, so again, if you want, you can ask it, not necessary. So now we are asking about non-GIT causes of vomiting. So for septicemia or meningitis, have you noticed any fever or any rash? If the child is a bit older child, like who can say what they are feeling, definitely you can ask about any headache, any neck pain or stiffness. You can ask about, does the light hurt his eyes, to look for photophobia. So those questions you can ask if it is a little bit older children. If it is an infant, all you can ask is fever and rash. For otitis media, have you noticed that he's complaining of any pain in his ear? So again, older children can say there is pain in the ear. For infant, they can't do that. So they will be pulling their ear. So for them, our question will be, have you seen that he's pulling his ear lately? Have you noticed any discharge from the ears? For pneumonia, any cough, any shortness of breath, any fever. Okay, so that's your differential diagnosis question one by one. So you have asked about bowel, you have asked about waterworks, intersusception, incarcerated hernia, then non-GI causes, meningitis, otitis media, and pneumonia. For every children, we always finish with these questionnaires, which is a well baby question, binds, and then we sometimes ask their TMAC, past medical history and family history. So that's what we follow. So our format will be like this. Now you have asked the differential diagnosis, then we will go for well baby question. So for well baby, we ask about their mental status. So is he active, irritable, or drowsy? We ask about their feeding and sleeping. So how about his feeding and sleeping? We ask about their bowel and bladder, which we have already asked in here. So we don't need to ask these questions anymore. Again, some people forget to ask this. So that's why we keep it in the format so that you don't forget. And also we ask any change in his body weight, which is very important to know for some cases. Like if it is a pyloric stenosis, there will be like a reduction of gaining of body weight. So that's important to know. So well baby question are mental status, feeding and sleeping, pee and poo, and then change of weight. After that, you go for binds. So binds is a mnemonic for birth history, immunization, nutrition, development, and social history. So for birth history, we ask about, very quickly, you can ask how was his birth? Was there any complication during or after delivery? Was he a term or preterm baby? And how was the mode of delivery, normal or cesarean section? So that's usually what we ask in the birth history. So we ask about how was his birth, any complication during or after delivery, was he a term or preterm baby, and what was the mode of delivery, cesarean section or normal vaginal delivery. So that's a short birth history. We ask about their immunization history. So is he immunologically up to date, or has he got all the vaccines? Any question will do, but as long as you're asking it. Nutrition, we don't ask this question quite often. Development history, how is his growth and development? Very, very important question for pediatrics. Especially if it is a pyloric stenosis child, they will also have, like, the child will not gain weight, child will not grow well. So growth and development will be hampered. And social history, mainly we ask about who do you live with at home? Are you a happy family? Have you got enough support at home? That's to the parent. Okay. But again, for this vomiting cluster, it is not mandatory to ask. So, but just ask birth, immunization history, and development history. So far, you have asked well baby question and binds. So binds means birth history, immunization, nutrition, development, and social. Then you will ask about TMAC. So TMAC is a mnemonic which covers travel history, medication history, allergies, and any contact. Contact is very important for children. So travel history, any recent travel to any recent travel to anywhere, or if it is if you're suspecting COVID or any kind of like infectious disease, you can definitely ask about any recent travel to interstate or overseas. So travel history is important. And for vomiting cluster, you can just ask that any recent travel to anywhere, is he on any regular medication, any known allergies, contact. So for contact, we ask contact at childcare and contact at home, childcare or school. So anyone in childcare has got the similar symptom. Anyone at home has got the same symptom. So that contact history. If the child is a bit older and going to the school, then you just ask anyone at his school has got the similar symptom. Okay, so that's TMAC, travel, medication, allergies, and contact history. And then lastly, finish with any other past medical history, any family history of any chronic condition. So that will be the end of your history. Okay. So to give you the summary, like a summary of this format, you'll first introduce your child is vitally stable. Then you will start asking questions about the vomiting. Ask all the vomiting questions. Then you can go to the differential, ask about bowel and bladder, and then intussusception and hernia, then non-GI causes such as meningitis, otitis media, and pneumonia, and then finish with well baby binds, TMAC, past medical history, family history. Now, if there is a lot of tasks, like 3 or 4 tasks in the exam, you will not be able to ask all these questions. Then you will prioritize which one is important. You can easily remove like travel history, medication, allergies. They are not super important. Contact is important. Same in here. Birth history, you can just ask one question. How was his birth? Was there any complication? That's it. You don't need to go too much detail. So you need to cut it short if there is a too much task. Okay. So that's the format. Any question with the format, guys? Are you with me?
Yes.
Okay. So let's move on then. We'll move on to the cases. So the first case is urinary tract infection. Very important for exam. So you have got a mother came with a 9-month-old child with fever and vomiting for the last 2 days. You are a GP. Your task is to take a history. Physical exam card will be given. Give the diagnosis with management. So it's a 9-month-old coming to you with a fever and vomiting. When you get fever with vomiting, you know that there must be something infectious going on, right? So then you'll start with the infectious causes first, and then you go to the GIT causes. In this case, the history will start like this. So you will start with the same way how we start. So start with reassurance, make sure child is stable, and then ask that, I know from the note that he has got fever and vomiting. Can you tell me a little bit more about it? Okay. Now, also we can ask that which one came first, fever or vomiting? And if fever came first, then you can start question about the fever. Like let's say we can say that I understand from the note that he has got fever and vomiting. Can I ask which one came first? The fever came first. Well, can you tell me a little bit more about it? So then they will give you some information. You need to know that when did you first notice it? Did you record the temperature? What was the highest temperature? Is it a continuous or on and off fever? Have you noticed any chills or shivering? Okay, did you give any medication? Did it help? So that's fever question. Since when? Did you measure the temperature? What was the highest temperature? Continuous or on and off? Any chills or shivering? Then ask the vomiting question, the same vomiting question that you have learned. Now that we know that patient has got fever with vomiting, we are going to first focus on the infection causes. So head to toe, infection causes, we are going to search for that. So we will start from the head to toe and try to find out from where the patient has got the infection. Okay, so head to toe, so you can have meningitis. So ask questions accordingly. So any fever, rash. So we already know the child has got fever, so our question will be any rash. If it is an older child, then we ask all other meningitis question. After that, you have got upper respiratory tract infection. So you can ask all about upper respiratory tract, which will also include ear. So ask that any runny nose, any watery eyes, any sore throat. Does he complain any pain in the ear, or does he keep pulling his ear? Any discharge in the ear? So ask all about ear, nose, and throat in the upper respiratory tract. So ask about the eye. So any red watery eyes. For nose, any runny nose. And then for ear, you know the question. And for the throat, any sore throat or any difficulty in swallowing, depending on the age of the child. Then you go to the lower respiratory tract, which is pneumonia. So any cough, any difficulty in breathing. Already we know the child has got fever. Then we go to the abdomen. So abdomen, we have gastro and UTI. So ask about gastro question, that means the bowel habit question, and then ask about the water work question. See that we are just flipping the question, right? So normally we would ask GIT causes first and then non-GIT causes, but because this child has got fever, we started with the non-GIT causes and then we are going back to the GIT causes. Okay, so after you have done that, then you ask all other GIT differential diagnoses as we did and finish with well baby binds. In the past medical history, ask about any past history of urinary tract infection or any kidney disease, any family history of kidney disease. The only positive finding in this case can be like maybe the parent will say the child cry while passing urine, or there is a funny smell from the urine. That might be the only thing that you can get. Or you might not even get that. Only finding can be fever and vomiting. And when you do a urine dipstick, you can see some nitrate in it. That's it. Okay, so because 9-month-old diagnosing UTI is not very easy. So how we do the physical exam in such case? So one, you know that physical examination card can be given in the exam, or you might need to tell the examiner that what finding you are looking for. So you will be starting with general appearance. If the child looks alert, drowsy, or irritable, any dysmorphic feature of Down syndrome, then you do the pickle. So any pallor, ictera, cyanosis. Very, very important for pediatrics, especially a vomiting child, is any sign of dehydration. For dehydration, we look for this finding. So we look at the capillary refilling time, sunken eyes, dry mucous membrane, and if the anterior fontanelle is depressed. Okay, so capillary refilling time, skin turgor, sunken eyes, mucous membrane, and anterior fontanelle. These are the things that we look for to look at dehydration in a child. Then we check the vitals definitely. So pulse, temperature, blood pressure, respiratory rate, and saturation. In pediatrics, growth chart is another thing that we have to ask. to every pediatric cases. So growth chart allows us to know that if the child is growing well, developing well. So we always check the growth chart of a child. After you have done the general appearance, pickled, especially dehydration, vitals, and growth chart, then you will start with the neck stiffness and ENT exam. So before neck stiffness, finish the ENT. So when we will discuss the respiratory system, you will know the detail of ENT examination. But just for today, it will be like in the ER, you will be looking for any tympanic membrane changes, any ER discharge. In the nose, you will be looking for any nasal discharge, any nasal mucosal changes. And in the throat, you'll be looking for any exudates in the throat, and if there is any tonsillar hypertrophy, any red inflamed tonsil. Okay, so that's ear, nose, and throat quick examination. So ear for any sign of tympanic membrane infection or inflammation, nose for nasal discharge and any nasal mucosal changes, and for the throat, you're looking mainly for any tonsillar hypertrophy or any exudates. Then you check the neck stiffness, which is very, very important for a vomiting child. Once you have done that, then you go on for a systemic examination. So you'll be doing you'll say that you would like to do the full body systemic exam, but mainly you will focus on the abdominal exam. So on abdominal exam, we do inspection, palpation, and auscultation. On inspection, you will be looking for any visible distension, any visible peristalsis. On palpation, you will be palpating for any palpable mass or any tenderness, and auscultation for bowel sound. With the consent of the parent, you will also check the hernial orifice, genitalia examination to rule out any torsion of testes, per-anal inspection for any red currant jelly-like stool for intussusception. Okay, so that's what we do in abdominal exam for a child who has like a sudden vomiting. So inspection for visible distension or visible mass. You can get a visible peristalsis in a pyloric stenosis child. Same, any palpable mass or any tenderness. You can get a palpable mass in pyloric stenosis or even in intussusception. Auscultation, bowel sound is important. If it is intestinal obstruction, bowel sound can be reduced. And then you would say that you would do the whole body systemic exam, including respiratory system, cardiovascular, and central nervous system examination. And then you would do an office test, especially urine dipstick for any leukocyte, nitrite, or red blood cell. Okay. When you say all of this, examiner will give you a card, and on the card, every finding will be given. That means what are the findings for this child you have got. That's one of the other way, which is not always the case. Very rarely I have seen this to come. But you should know that how we do the physical examination of these cases. Okay. So to summarize the physical exam, general appearance, pickled vitals, growth chart, ENT exam, then neck stiffness, and systemic exam, mainly focused abdominal exam, followed by a quick other systemic exam, and office test, mainly urine dipstick. Office test means bedside test. So in this case, you will get nitrite positive in the dipstick. So you have got nitrite positive, 9-month-old, fever and vomiting. Okay, that's more than enough to say that this child has got a urinary tract infection. So how you're going to explain this to the parent? You're going to say that, thank you so much for all the information that you have given to me. From history and physical exam, most likely your child is having a condition called urinary tract infection. Do you know about it? No, doc. Or they can know. So many parents know what is urinary tract infection. So you will say that, well, as you know, that it is an infection of the urinary tract caused by a bacteria. Okay. Now, if you can explain the kidney, ureter, bladder, and explain how this urinary tract infection occurs if you have some time. Otherwise, just say very simple way that it is an infection of the urinary tract caused by a bacteria. Now, the female's urinary tract is very close to the back passage. So sometimes bugs can easily enter into the urinary tract from the back passage, and which can cause infection of the urinary tract. And most of the time, the child will present with fever, vomiting, and with painful, smelly urination. Are you with me so far? Are you understanding me, Jenny? Okay, so just explain what is urinary tract infection and what is the main symptom of it. And then you go for management. If you want, you can give some differential diagnosis here if you have time. So you'll say, as your child is still 9 months old, and it is considered to be a part of the vulnerable group of patients, I need to send your child to the hospital by ambulance. In the hospital, she will most likely be admitted and will be seen by a child specialist for further evaluation and management. Okay, so any child who is less than 12 months having fever and vomiting, even if you know that it is urinary tract infection causing this, the best idea is to send them to the hospital for further management, because anytime they can develop septicemia. Okay, and just by urine dipstick in a 9-month-old, you can't diagnose with UTI because many times it can be contaminated. So you need to do a proper investigation to find out the actual bacteria causing this. If it is more than 12-month-old, then it's not necessary that you have to send a child to the hospital. Okay, you can treat them with oral antibiotic in your GP clinic. But if it is less than 12 months, then yes, we're going to send the child to the hospital for further assessment. So you'll say, as the initial urine dipstick is just a screening test for the infection. So because the initial dipstick is just a screening test and many times it can be contaminated, most likely in the hospital they will take another urinary sample, probably by a method called suprapubic aspiration, and then send the urine for confirmation of the diagnosis and find out the exact bacteria causing this. In this procedure, a needle will be inserted just below her umbilicus or belly button, and a sample of urine will be collected from there. Please don't get scared. It will be totally pain-free and will be done by a very experienced doctor. Now, when you say this line, every parent will be very scared. So you'll have to give them proper reassurance that please don't get alarmed. It is a pain-free procedure and will be done by an experienced doctor. If the parents say, doctor, is there any other thing that they can do without just going for like inserting a needle into my baby? Then you have to say that I understand that this is scary for you. And believe me, I would be also scared if I was in your place. But most important thing is to find out the infection which is causing this symptom. And if we don't find it out, and then sometimes we are not able to treat it accordingly. And this infection can spread to your baby's whole blood and causing a life-threatening complication. So that's why it is needed, and that's the only way that we can get a confirmatory test for a less than 12-month-old child. Okay, so you have to say something like this so that parents understand why you are saying that the child needs suprapubic aspiration. Then you will say that once the urinary sample is taken, specialist will start your child with an antibiotic to fight the infection, and also Panadol or paracetamol to address her fever. Most of the time, that is the treatment that they do if it is for the first time your child has got a urinary tract infection. But for children who gets a recurrent urinary infection, the specialist might want to do further investigation to check their urinary tract as a whole. They might want to do an ultrasound of the full urinary tract to rule out any structural abnormality causing this infection. In some children, a specialist might also want to do another test called micturating cystourethrogram, where a special dye is inserted into the urinary tract to look for any abnormality. But as I said, that as your child has got the infection for the first time, most likely that is not what a specialist will do. It is usually done in a recurrent urinary infection child. But again, it depends on the specialist what they want to do about it. So as you know that for first time urinary tract infection, it is not a mandatory thing that we have to do ultrasound and a micturating cystourethrogram for a child who has got UTI. But if it is more than one or recurrent UTI in a child, definitely this has to be done. And then at the end, just to reassure, say that, Jenny, please don't worry. Most of the children with urinary tract infection make a good recovery and have no future problem. And it is a very common infection. Please try to wipe her from front to back and give her ample amount of fluid when she goes home. Okay, if it is now, it's in the GP clinic, right? So you are already sending the patient to the hospital. So you can say, I will give you some reading material about the urinary tract infection while you are going to the hospital. And I would like to see her once she's discharged from the hospital. Okay, that's it. So that is the management of urinary tract infection in a child. Any question? The vulnerable group means the children less than 12 months, they can easily get septicemia. So any less than 12 months having fever and vomiting, we are concerned about septicemia, especially if it is a urinary tract infection. It can easily go into the blood. And how much time you get for a task? You get 2 minutes to read a task and 8 minutes to perform a task. And suprapubic aspiration up to 12 months. And then between 1 to 4 years, you can, if you can do a clean catch urine. So while the child is urinating, parents will try to catch the urine. That's clean catch urine. And more than 4-year-old, we go for midstream urinary collection, which that means usually after 4, child can pass urine on request, right? So if you ask the child to pass urine, they can do it. So for them, midstream urination. For between 1 to 4, clean catch urine, and less than 1 year, they would go for suprapubic aspiration to collect the urine. Okay? So this is how you'll have to do this urinary tract infection case. It is a tricky case. A lot of students fail this case just because they don't know how to say these things. Okay? So try to make sure you reassure the parent a lot during this conversation. Any question about the UTI in a child? And again, as you could see that we don't need to say the name of the antibiotic or anything. So you just say antibiotic, that's it. But the antibiotic for UTI in children is most of the time we go for cephaloxime. Moving on to the next task, you are a GP. So this is gastroesophageal reflux. You are a GP, a mother brought 4-month-old baby girl. She says the child vomits after feeding. There are no other symptoms. Mom thinks the bottle feeding will be better for him. So vomiting after feeding for a 4-month-old. So what is gastroesophageal reflux? Gastroesophageal reflux is a physiological thing that happens in every children who are less than 12 months. So it means that gastroesophageal reflux is the passage of gastric contents into the esophagus, right? Now, it is a physiological process that occurs several times a day in a healthy infant. Its clinical presentation is vomiting. Majority of cases, it is self-resolving and does not need any treatment. At 12 months, only 5% of child will have this problem. Okay? So gastroesophageal reflux is normal and it's common. There is nothing to be concerned about it. But what is concerning is that if with gastroesophageal reflux, children has these symptoms. So if a child with reflux, like that means vomiting after feeding, having pronounced irritability with arcing of their back, refusal to feed, loss of weight, hematemesis, chronic cough, wheezing, and apneic episodes. If any of these are associated with reflux, then the term becomes gastroesophageal reflux disease, which is pathological. All right? So your history will be totally same. Nothing different, but only thing you will add in the history is this red flags. So the positive points in the history was child vomits after feeding. The vomiting is white in color, that means the breast milk is coming out. Sometimes it can be projectile, but child is gaining weight. Now that is the main part. If it is a pyloric stenosis child, the child will not gain weight, but reflux child will gain weight properly. All examination will be normal, and also there was no sign of gastroesophageal reflux disease. Okay, so same history and physical exam. Only thing is that you are going to ask these features. So you will ask the parent when you are asking the history. In the well baby question, you can ask that how is his feeding and sleeping, right? So if there is a refusal to feed, parents will say at this time. You can ask that, have you noticed he is getting quite irritable with arcing of the back? So that's one question you will be asking. We ask about the weight loss anyway. We ask about any blood in the vomitus, so nothing to be added in here. You can ask these two questions that has he got a cough for a long time, and also have you noticed that he stops breathing for a few seconds at night. So stopping breathing for a few seconds while sleeping, that's apnea. So few questions of gastroesophageal reflux disease you will have to add. Okay? Otherwise, history and physical exam is exactly same like the format. So how we are going to explain gastroesophageal reflux in a parent? So you will say that from history and physical exam, most likely your child is having a condition called gastroesophageal reflux. Don't say reflux disease. Do you know what it is? No, doctor. Well, the lower part of the food pipe, where it connects with the stomach, is poorly developed in babies. Okay, so lower part of the esophagus, where it gets connected with the stomach, is poorly developed in babies. That is the reason why the milk in the stomach flows back into his mouth when you put him down. So most of the time, reflux symptoms will be when the parents feed the child and then put the child on the cot for sleeping, then this happens. Okay, so it is common. So you'll say, please don't get scared. It is a very common condition where baby vomits after each feed, but otherwise he gains well and thrive well. This usually improves with the time, especially after introduction of solid. Majority of cases clear up by 1 year of age. But it could be due to other causes as well. Then you can give some differential diagnosis if you like. For management, there is no specific medication that I need to give you. All you need is to follow some lifestyle modification. So I would recommend you to give him a small frequent feeding rather than a large meal at a time. Try to decrease the duration of feeding along with the time in between. Also, you can thicken the feed with some food thickeners such as Gaviscon. So easily, the breast milk also can be thickened, and also the solids. Usually, when they start solid, this problem usually is no longer there. So they can always thicken the breast milk, like they can express the breast milk and then thick with the Gaviscon, right? So you can always thicken the food, or you can always thicken the feed with some food thickeners such as Gaviscon. You can also elevate the head of the cot by 10 to 20 degrees. After each feed, please do not put the baby immediately to sleep. Carry him for a while and put him in cot with head elevated. So elevation of the head is good. We highly recommend breast milk because it is best for your baby. Why we say this line? Because if you go back to the question, mom thinks the bottle feeding will be better for him. We don't recommend bottle feeding, we recommend breastfeeding. If it doesn't help in few weeks, and if it's get worse, then definitely I can send your child to a pediatric gut specialist who might consider starting some acid suppressant therapy. But most of the time, it doesn't need it. Please don't worry, as long as your child is growing well, feeding well, there is nothing to be afraid of. I will regularly review him and I will give you reading materials. At any time, if you find that he's getting irritable with arcing of his back, he's refusing to feed, losing body weight, getting cough or stop breathing for a few seconds while sleeping, please bring him back to me immediately. That's the red flag. Okay? So that's usually your gastroesophageal reflux management. There is no investigation needed, and ideally just changing the way of feeding that usually helps, and your reassurance helps a lot. Any question, guys? And Dr. Shidhant, below 12 months, male-female ratio is similar. Yes, because the urethra is still small. When do we need to admit an UTI case? It's a vast thing. For pediatrics, especially less than 12 months, you are going to admit the child and see, and you do the suprapubic aspiration, make sure child have some antibiotic, and then you can send the child home. Okay. For more than 1 year old, it's not always necessary that we need to send the child to the hospital even. Okay. What are the signs of reflux disease in examination? In examination, you can ask about if the child looks irritable with arcing of the back. That's all that you can ask. Apart from that, you can't ask any other physical examination finding. So yeah, dehydration, weight loss, you can ask. And Dr. Shahan, yes, definitely, if it is a reflux disease, usually child will not gain weight properly, or they can even lose weight. All right, guys, so now I would like to take a 5-minute break, and after that, we'll be doing some more cages. Okay, thank you, guys. All right, everyone, let's restart. So we have got few questions for UTI. So Sherry, so if child is more than 1 year, and we say that we are going to take another urine sample with clean catch method, and we'll give him antibiotic. The thing is that it's not that always a more than 1 year old child you will always be able to treat in the GP clinic. Depends on the severity sometimes. If the child is vomiting a lot and looks drowsy, dehydrated, then even for more than 1 year old, the child will go to the hospital, right? So depends on the vitals, depends on how unwell a child looks like. But if the child looks well, it's not like having very high fever and child is not that much dehydrated, then you can treat them in the GP clinic. And yes, because dipstick is not the best test, and we need to know how the dipstick was taken. Was it like, because for dipstick they need a urine, right? And so how that urine came. If the urine was like for the dipstick, if the urine was taken by clean catch method, that's fine. We will just send that urine to the lab. Okay. But if the dipstick was not taken by a clean catch method, then yes, we will need another sample, and then we start him with antibiotic. Okay. And shall we send the urinary sample for microscopy and culture? Yes, we do. Next question, pyloric stenosis. You are a HMO in emergency department, a 6 weeks old baby coming with a vomiting with mother. History, physical exam, so same thing. So 6 weeks old. Pyloric stenosis is usually common between 2 to 6 weeks of age. So positive finding in the history is that child started to vomit at around 6 weeks of age. So this kind of vomiting will not be like since birth. It's not like that. So maybe for the last 3 to 4 weeks, child has been vomiting. The vomiting will be non-bilious, which means not greenish in color. So definitely the breast milk is coming out. It's getting progressively more forceful and become projectile. Child gets hungry afterwards, and there is weight loss. So that's the main thing, that the child having a short period of vomiting after feeding, and immediately getting hungry afterwards, and become progressively forceful, and definitely there will be weight loss in this child. Physical examination, you might get child is dehydrated. When you do an abdominal exam, you can see the gastric peristalsis. So on inspection, you can find out some gastric peristalsis, which is a wave of contraction across the abdomen coming from the left upper quadrant to the right lower quadrant, like this. So you can see a visible peristaltic wave across the abdomen. You can also feel a pyloric mass, and the mass will be size and shape of an olive. So an olive-shaped mass can be felt in the right upper quadrant. Okay, so this is not like always will be there, but if you get this finding, then you can be definitely sure that this is pyloric stenosis. But it's not always that we are able to get this gastric peristalsis or pyloric mass. Okay, there is a test called feeding test. So you ask the mother to feed the child, and you will see that immediately after feeding, child is having a forceful projectile vomiting. That's feeding test positive. Now, once you have got all of these findings, so you have got a child who's been vomiting for a few weeks and getting like not gaining weight or losing body weight, projectile forceful vomiting. On the examination finding, you have got some of these findings. Then you know that this is pyloric stenosis. So you'll explain that most likely your child is having a condition called pyloric stenosis. Do you know what it is? No, doctor. Well, let me explain in detail. So the milk goes from the mouth through a tube-like structure called food pipe. and from the food pipe, milk will reach to the stomach. From the stomach, milk then goes to the small gut and then to the large gut. In pyloric stenosis, the lower end of the stomach, called pylorus, get narrowed. And because of that, milk or whatever your child have cannot pass down to the small gut, and child vomits it out. And due to the vomiting, he gets hungry immediately after feeding. And most importantly, he's not able to get enough nutrition to gain body weight. That's why he's losing weight and he's losing fluid from his body and also not gaining adequate weight. I am very sorry to say, but this is an emergency condition. And Jenny, he needs an operation to fix this problem. That's why I need to call an ambulance. I will arrange a pediatric emergency retrieval team and arrange transfer of your child to the nearest hospital. So if you're a GP setting, you will need to send the child to the hospital immediately. Now, it's not always that you have to arrange an air ambulance for the child. You can send the child through the ambulance as well if the hospital is 30 minutes away. Okay, but if it is let's say 1 or 2 hour away, then definitely you will just arrange a pediatric emergency retrieval team and send the child to the tertiary hospital by air ambulance. Okay, so definitely this child will go to the hospital. In the hospital, he will be seen by a child specialist for further management. Diagnosis is usually clinical, but they might want to do an ultrasound scan to confirm. They will also do frequent blood tests to check his salt and mineral balance and also his acid-base levels. Now, if the child is dehydrated from your examination, then you will say, as your child is dehydrated, I will also start him on fluids through an IV line. Please do not feed him from now onwards because this can make his vomiting worse. If your child keeps on vomiting even after you stopped feeding, they might also want to insert a tiny plastic tube through his nose down to his stomach to remove any of the left out contents so that the child stops vomiting. Once your child is stable, most likely an operation will be needed to fix it. Now, when you say a 6 weeks child will need operation, any parents will be devastated. So in those situations, you will need to be reassuring. Your words matter a lot in these cases, right? So having a pyloric stenosis doesn't mean that child will not live. Child will live, right? You will explain that, Jenny, I understand that it came as a shock to you. And I can't begin to imagine how you must be feeling right now. But I want you to know you have done a very good job by bringing him here as early as possible. And with appropriate treatment and surgery, usually this kind of condition can be resolved with any complications. Okay, but as I am not the surgeon, the surgeon in the hospital will discuss in detail about what kind of operation he might need and what are the risks associated with the surgery and everything. But I want you to understand that your child is in a safe hand. Your child most of the time would be able to start eating and drinking within 6 hours of the operation. And once the problem is repaired by surgery, it is unusual for it to come back again. Okay? If you want me to call your partner, friends, or relative, I am more than happy to do so. And in the meantime, while we wait for the ambulance to come, we will just start an IV line to start IV fluids so that your child doesn't get any more dehydrated. Do you have any questions? Okay, so that will be the explanation of pyloric stenosis. Definitely, you will need to explain what is pyloric stenosis in detail, and then talk about sending the child to the hospital. What will happen in the hospital? They will do blood test, they will do an ultrasound, and then they might need to even put a NG tube if child keeps on vomiting. And then definitely the child will need a surgery. Okay. Any question, guys, with the pyloric stenosis? In GP clinic, IV cannulation is available or possible, or we won't see such case in GP. Is feeding test necessary to discuss? Feeding test is not necessary to discuss. And GP clinic, yes, GP clinic IV cannulation is available and possible. So if it is, and now for an infant, it's very unusual that GP will do a IV cannulation in the sitting, but you can definitely say that, okay, if needed. But in real life, no, very unlikely we would do it. Role of antiemetic, no need. For children, antiemetic is not going to fix this because the main problem is pyloric stenosis, right? Next task, intussusception. You are a HMO in ED, a 5-month-old boy with multiple episodes of screaming for the last 6 hours, has vomited twice in the last 3 hours. So you have got a child who has got these screaming episodes for 6 hours. So this is the acute screaming, and also child vomited. Okay. So you're getting the hang of this case. So first of all, again, this case is a very acute onset of vomiting and screaming. Same history. So you'll go in, make sure child is stable enough, and then you start asking about the screaming episodes. The HOPC, or history of presenting complaint. You'll ask an open-ended question about, can you tell me a little bit more about these screaming episodes? So once they give you some information, you'll just say, you'll need to find out that since when it started, is it for the first time? Anything particular happened before these episodes? Like a child can have a inhalation or ingestion of a foreign body, and that can also cause screaming. So you can definitely ask, anything particularly happened before these episodes? Is it continuous or episodic? How many episodes of screaming so far? And does he draw up his leg while crying? Does he turn pale? So this is a specific question for intussusception. Okay. So you have asked about the screaming episodes. How many episodes so far? Since when? What happened exactly before the episodes? Continuous or on and off? Okay. And then ask about the vomiting question. So all the same vomiting question, and then you go for all the differential diagnosis. So ask about the bowel, bladder, ask intussusception, hernia. So same questions as we asked in the format. For intussusception, we also can add few things. One, that have you noticed any loose stool or any red colored stool? Because red currant jelly-like stool is very common for intussusception children. Okay. Apart from that, everything is same. Finish with well baby binds, past medical and family history. Physical examination will be same like before, but the finding you can get in here, because intussusception is kind of an obstruction, so child can have distension of the abdomen. On palpation, you can feel a sausage-shaped mass. You can also get emptiness in the right iliac fossa. On auscultation, you can get alternating areas of high-pitched bowel sound with absence of bowel sound. So these are the main findings. Palpation, sausage-shaped mass, especially more noticeable when child cries, emptiness in right iliac fossa, and then this bowel sound alternate with high-pitched with absent bowel sound. Then with the consent of the parent, you will check the hernial orifice and definitely perianal inspection for any red current jelly. Okay, so you know the positive points, what this child will have: episodic crying with child drawing up the legs. During the episodes of crying, child becomes pale. Child will be very lethargic because obviously he's in pain, he's vomiting. Bowel motion, they can have diarrhea, loose bowel motion with a classic red currant jelly. Diarrhea is quite common, and many times intussusception can be preceded by a recent diarrheal or respiratory infection. So how you are going to manage intussusception? So you will explain that based on the history and examination, most likely your child is having a condition called intussusception. Do you know what it is? No, doctor. Well, it's a sliding of one part of the gut into the other. So basically what happens is that if this is one bowel, then the other bowel gets trapped into this. So it's kind of a telescoping or sliding of one part of the gut into another. Because of this sliding, the bowel can get blocked or obstructed, which causes this pain and vomiting. Left untreated, the part of the bowel which is getting blocked will not have any blood supply and it can have irreversible damage. That's why it is an emergency condition. We need to admit your child, and also I'm going to involve the child specialist immediately. Now, when you say it is an emergency condition, reassure the parents. At the same time, we always use the sandwich approach. If we say something bad, at this just next line we say something good or reassuring. So we'll say that please don't get scared about it. You are in a safe hand. We have a very good team of doctors here who is going to take care of your child. In the meantime, while we wait for the child specialist to come and review, please do not give him any food or drink. And I'm going to insert an IV line and start him on IV fluid. Specialists might also want to do an ultrasound and X-ray of his tummy to rule out any obstruction. Once the diagnosis is confirmed, treatment is usually done by a specialist, a radiologist, and a pediatric surgeon. They usually start with an air enema, which is passing a small tube at his back passes, and then they pass a bit of air through it. And when they pass the air, the blocked gut can become unblocked and the problem can be solved. Please don't get scared. I understand it sounds very, very scary. But throughout the procedure, your child will be monitored by a very experienced specialist and he will be under sleep, so you will not feel any pain. Unfortunately, if this procedure is not effective, then your child might require surgery as well. I hope that the air enema will work for your child, but even if it's not, even if your child requires surgery, we have a good team of pediatric surgeon in here who is going to take care of your child. Then just the same reassuring thing as we say always. So if you want to call your friends, relatives, partner, please tell us. We will be happy to contact them. So say something nice and good at the end. Okay. So that is intussusception. Basically, you'll have to explain what is intussusception, why it is emergency, and definitely the main treatment is initially you insert IV line, start IV fluid, don't give any food or drink. If child keeps on vomiting, then again NG tube might be needed. The investigation we do is ultrasound and X-ray, and then the management is air enema. If that's not effective, then surgery. Okay, cool. Moving on to the next one. Any questions, guys? Okay, during the feeding test, should we palpate the pylorus? You can, it's not needed. But pylorus, you can, okay, but it's mainly about the intussusception where you get like when the child cries, then you can palpate and you might be able to feel some mass there. But for feeding test, we do actually just check for if the child is vomiting or not, and if we can see some gastric peristalsis when the child is feeding. And the NG tube is for children who keeps on vomiting even after the mother stops feeding the child. Okay, so it's for like ongoing vomiting, then NG tube is needed, not initially. Moving on to the next case, incarcerated hernia. A 5-month-old boy coming with GP clinic with his mother because of sudden onset intermittent screaming with a few episodes of vomiting. So this one also having intermittent screaming with vomiting. So it looks like same like intussusception. Older brother has got a recent gastro. This is just a trap or to make you confused. That's one question. Another one is 3-month-old, irritable baby for 3 weeks. Today, mother noticed a lump on the inguinal area. So different kind of scenario. One that there is a lump on the inguinal area, you already know it. Another one is just a screaming with vomiting. So screaming with vomiting, that will be exactly same history. The finding will be that mother might say that yes, I have noticed a lump on his groin. Sometimes even that finding might not be given. Parents might miss it. They might not even notice a lump, right? So just don't think that always in the history this will be given to you. But when the physical examination card will be given, then they can give you either a picture or they can say that there is a tender, irreducible inguinoscrotal swelling. So if it is an irreducible inguinoscrotal swelling, you know that this is an obstructed or incarcerated hernia. Okay? So how will you manage this? So for incarcerated hernia, you will say from history and examination, most likely your child is having a condition called incarcerated hernia. Do you know what it is? Well, let me explain in detail. A hernia is the protrusion of part of the gut or fatty material through a weakness or opening in the tummy wall. So that's hernia, right? It's a protrusion of the either it's the gut or a fatty material coming through a weak point of the gut. It's usually seen as a bulge or a lump under the skin along the groin area. In a simple hernia, the bowel or the fatty tissue are able to move freely in and out of the defect, which is what we call as reducible hernia. But sometimes if the part of the bowel becomes trapped and it cannot return back to the tummy, that's the time we call it irreducible or incarcerated hernia. Now, because the bowel is no longer able to go back, it starts to get lack of blood supply, and at some point, it does not get any blood supply and it has a risk of irreversible damage. Left untreated, that part of the bowel can die, and it can even sometimes perforate, causing a life-threatening complication. Please don't get scared about it. I am not trying to scare you, but I want you to understand that you have done a very good job by bringing him here as early as possible. We have a very good team of doctors who is going to take care of him. But as you understand that this is an emergency situation, we need to admit your child now. I'm going to call my senior and also a pediatric surgeon to come and have a review. In the meantime, please do not feed him or let him drink water, and we will put some IV line, start him with IV fluid. Most likely, a specialist will go for a surgery to put the blocked gut back inside. Please don't get alarmed. We will do our best to manage this condition. And the surgeon will come and discuss in detail about the surgery, how it's going to happen, what's the risk and procedures, everything. If you have any concern, if you have any questions, feel free to ask the surgeon about it. And I'm also more than happy to answer any queries that you might have. Okay? And lastly, just finish. So because this is in the hospital setting, you don't need to give 4R in here. So there is no need of doing 4R in a hospital setting. Okay? Any question with incarcerated hernia, guys? Definitely, we can give some painkillers. Yep. So the only painkiller you can give in this case, it will be just a paracetamol or Panadol. Okay. Yes, definitely we can offer some Panadol for the pain. Okay. The last case for tonight, duodenal atresia. It's a very important case, comes in exam a lot. So you are working in a small country hospital as a HMO. You have been called to talk to a 27-year-old mother, Janelle, who gave birth to a baby boy 24 hours ago. She has started breastfeeding, but he has vomited several times, some greenish fluid, and hasn't passed any meconium yet. The neonatal checkup did not reveal any pathological finding, and anus was present. Abdominal X-ray is provided, and it looks like this. What you see on this X-ray is called double bubble sign. So see the two gaseous structure, that's double bubble sign, that's pathognomic for duodenal atresia. So you take a brief history from the nurse, explain the X-ray finding to the mother, discuss the most likely diagnosis and management with the mother. So history can be from the nurse or from the mother, any of them. And you have to explain the X-ray to the mother also. So you will know how to explain X-ray to the mother in here. So first of all, in this question, you'll follow the same pattern. So introduce, reassurance, then vitals, ask about the vomiting, ask all the vomiting questions one by one. And then you ask about bowel, bladder, and rule out non-GIT causes. So same thing, nothing is different in here. Okay, so history will be totally same. Only thing in duodenal atresia we want to ask is about Down syndrome screening, because most of the children who gets duodenal atresia has Down syndrome. So when you ask about the birth history, just ask that, did you have a Down syndrome screening when you were pregnant? That's one of the good questions to be asked. Otherwise, nothing you need to add in here. Second task is to explain X-ray to the mother. So how we explain X-ray in a layman term, that comes in exam a lot. So you will say in here that, well, Jenny, let's have a look to the X-ray of your child's lower chest, abdomen, and also upper part of his leg. Okay, or you can start in this way, that Jenny, thank you so much for all the information that you have given. Now, given the history, we have done an X-ray of your child's abdomen. Now, let's have a look and see what we can find out from it. If you don't understand at any point, please do not hesitate to ask me. So, Jenny, when we look at an X-ray, we look for a few shadows. Some are black and some are whitish in nature. Blackish shadows are what contains air in it, and whitish are which consist of bone or which contains fluid or blood in it. Are you with me so far? Yes, doctor. Well, now, if you look at your child's X-ray, you can see that on the upper side, you can see there is two blackish shadow, and that's the lower part of his lungs. And in the middle, you can also see a whitish shadow, which is just lower part of his heart that we can see. Can you appreciate those? Yes, doctor. Now, if we look at the abdomen or in the middle of the X-ray, you can see there is two rounded black shadow. Can you appreciate them? Yes. So those two rounded black shadow that you can see, those are commonly known as double bubble sign. And this kind of double bubble sign is usually we find in a specific condition called duodenal atresia. Do you know anything about duodenum or duodenal atresia? No, doctor. Well, duodenal atresia means that there is absence of part of a small gut called duodenum in your baby. If I want to explain in detail, is that when your baby or when you try to feed your baby, the breast milk goes through his mouth into the food pipe, then it goes to his stomach, and then it goes to the small gut. The first part of the small gut is what we call as duodenum. In your child, unfortunately, this first part is missing. I'm so sorry to give you this news. I wish I could give you some good news today, and I can't even imagine what you're feeling right now. Jenny, this is not a very common condition. Many times we see that it is associated with some other congenital anomalies, but we haven't found anything like that in your child case yet. But left untreated, your child will not be able to have any breast milk that you are giving to go from the stomach to the rest of his gut, and which means that he will not get any nutrition that is needed. For now, we have inserted an IV line to make sure he gets enough fluid. We can also, if he continues to vomit, we might also need to put a tube down his mouth and into the stomach to relieve any contents from it. And then, the most importantly, your child will require a surgery to repair this defect. Okay, so that's mainly the management in this case. It's the same thing. As you can see, the management is totally same. How you explain is a bit different, but you will need to say the same thing. So admission to the hospital, pediatric surgeon will come and have a look. And then if you look over here, you are in a small country hospital as a HMO. Now, in a small country hospital, this cannot be treated. So in your management, definitely you will explain what is duodenal atresia and why it is emergency. And then you will say that because this is a rural hospital and we don't have enough means to treat your child, so I need to send your child to the tertiary hospital as soon as possible. So I'm going to arrange an emergency transport retrieval team, and your child will be sent to the hospital by an air ambulance as soon as possible. I will also liaise with the pediatric surgeon in the tertiary hospital so that they are ready for your child. In the meantime, I will insert an IV line, start him with IV fluid. Okay? And in the hospital, he will be admitted, seen by a child specialist, and most likely he will require a surgery to repair this defect. Okay? So that's all about duodenal atresia, guys. So this is more or less about vomiting cluster. Now, did you see that how many cases we have done with just single format? And that is why cluster-wise approach is very, very important. It's super effective. And you could see that we did not need to go through the history or physical exam. We just needed to go through the explanation of these cases. Let's see. Okay, simple. So Piper is just a pediatric emergency retrieval team. It's the like how the child usually will be transported by the air ambulance. Yeah, so if it is in a rural setting or incarcerated hernia, also it will be referred to tertiary. And Dr. Soeta, yes, you can give painkiller to the child if it is an obstructed hernia. Just a simple paracetamol will be the case. Okay. Any question, guys, about today's class? So our vomiting cluster is finished. So interoception physical exam. Let's see. Okay, so yes, you can still enroll for the course, and our course is still ongoing for admission. Now, definitely, this is the end of our free 2-week session. And I hope that you enjoyed our session. You learned a lot of things. And I'm sure there is no course which provides 2 weeks free session like this, but we do it just to make sure that you understand how we usually take classes. Okay? And I hope you enjoyed it. I hope you learned some things that will be important for your exam. And you can utilize this to have a good format in your head, to have a good approach in the exam. That matters a lot. Now, I will go through with the course discussion, like we'll just go through some of the clinical course details so that you know about the course. And then you can also ask questions to me. So I'm unmuting everyone. So you can unmute yourself and ask questions if you like. So this is a 5 months AMC clinical course, but if we started on March, so most likely it is going to be finished on end of July or first week of August. That's what we are mainly preparing for. If you finish the course in late July, so August and September you will just revise, and October, November will be your time to prepare for the exam. And I'll ask all of you to go for the exam by that time if you can. Okay? So we have taken trial class on 25th of February, where we did the MSc theory class. And since then, we have this 2 weeks free session running from 10th of March till today. We have done a lot, and all these class recordings are given in our First Aid AMC Clinical Facebook group. The course includes everything that any candidate need to pass this exam in the first attempt. And our candidates pass the exam in first attempt, not in third, fourth attempt. Okay. Even there was one student, just she has passed yesterday. She was our last batch student. She did not even need to like finish our full course. She just went through the recordings, and within 4 months, she appeared the exam and she passed the exam in her first attempt. So I said to all of you that it's not like that if you don't have 5 months time, you have all the resources that you need already in the portal. All the previous batch recordings are given to anyone who pays the full amount. We just give it to them from the day one. So you have every resource already available. So if you have a lot of time, you can finish it in your own way. Okay, you can pass the exam even before October, November. But you need to do your hard work. The course will cover all the theory based on cluster-wise approach like you have seen. We do the role play on this cluster-wise as well. We discuss 4-year sample question discussion and currently focusing on 2024 and 2023. You will have one or some days 2 role play classes every week. Okay, so most of the time our theory classes will be 2 days theory class, 1 day role play class, and some week you will also get 2 theory class and 2 role play class. Okay, so that's a lot for any of you to do any kind of role play if you want to come on the live sessions. Not only that, the course will provide video recording of all the role play classes we have taken so far, which currently we are at 141 videos. So that's a lot. Okay, it covers almost any kind of cases that can ever come in any exam, not just AMC, in any exam. There is no cases that can be left with 300 or 400 cases. Okay, but definitely you don't need to like go through 300 cases one by one. Follow the cluster wise approach that we are doing, and then you will see that most of the cases are coming in between the cluster. The physical examinations, usually we do it in our second or third month of the course. So after 2 months, the third month will be the physical examination month, and we reserve 1 month just for the physical exam. Online mini mock exam will be taken. Communication patient-oriented approach, we do some classes on that, and there will be recordings of these classes in your software even after finishing your classes or even after finishing your course. And the course note will be there until you pass. We are going to have a discussion on APRA registration, RMO campaign, career pathways just in a week. I'm hoping that you guys have seen the post. So career guideline session is a must to attend. So please attend that session. That's free for everyone. But we discuss things that you would never know if you don't attend these kind of sessions. CPD points, if you are a member of RSC GPA or ACRAM, and if you don't have 5 months time, then yes, you can finish it with our previous batch recording even within 1 or 2 months. Course cost is $899 Australian dollar, and this is the most affordable course which run by any Australian courses as part of AMC. Okay, it's not just like we don't ask you to ask for a $10,000 because that's insane, but a lot of courses do that. But even with a lot of inflation in Australia, we kept the course as affordable as possible. Okay. Course duration is 5 months. Classes are 3 days a week at the moment, 8:30 to 10:30 p.m. And if you want to enroll, still now you can. Our orientation class is on 27th of March. I would definitely advise to get enrolled or get added to our Facebook course group before the orientation class. Okay, the Zoom ID password will be given from now onwards to our course group. So if you are a member of the course, then you will be able to get it. If you want to enroll, either you can send me an inbox through my messenger, or you can also go through our email from here. So you can send an email to this firstaidamc4536@outlook.com, and our team will be in touch with you. Okay, that's all about the course that you will need to know. Any question, guys? And about the online exam, we will discuss online exam scenarios in our orientation class. And also we will take a class just on online exam. So we asked one of our recently passed online exam candidate to take a discussion class with you so that she can go through the recent online exam format. So we normally take those sessions in the early few months of the course. So everything that you need to know about online exam will be discussed. I will discuss few in the orientation class, but there is a separate class just to discuss how online exam works. Do we need to ask about torsion question in all cases of vomiting? Not really. For infant, it is not very common. And most of the time, if it is a torsion, they comes to you with a groin pain or a testicular pain. So it's not very important. After first installment, everyone needs to pay the second installment in 2 months' time. How long will cluster class continue for? Throughout the 5 months, cluster class will be continued. When do course students get scheduled for further classes? We have already given schedules in our Facebook course group, Dr. Nadim. If you're not a part of that Facebook course group, please make sure you inbox me as soon as possible. Where can we study the theoretical part of the disease symptom investigation management? The thing is that the note has everything that you really need for the exam. You don't need to go through it too much from anywhere. But if you want to know a little bit more, then RSCGP is the main for pediatric RCH. Same like MCQ, so you can get theory from them. You need to follow something as an Australian guideline. This lecture, all lectures are in a website, Dr. Shiplo. What is mini mock test will we be added to the newer group immediately as an enrolled student? No. You have to send me a message that you have paid the payment, and then we add you there. Anyone who pays, you immediately will get an email relating to what you need to do next. Okay. So based on that, we write everything. What's the next step? One of the steps is for you to send me a message so that I can add you to the Facebook group. Okay. And make sure you send a friend request in my Facebook so that I can add you. And you get the passcode in the Facebook course group, not the official group. So there is a separate group for the course students. If any of you are not added there, we have invited a lot of you. Many of you did not accept the invitation. So that might be the reason why you're not added. So make sure you send me an inbox. Passing rate of the clinical exam. Now, clinical exam passing rate, not even AMC usually gives us an idea about it. The passing rate is not like that high like MCQ. That's understandable because there is the last exam. Last exam is always the hardest one. So it's not like everyone passes the exam. A lot of time you might need to go for few attempts if you're not well prepared. Okay, but I can't give you a specific rate because every month it is different. It depends on your on that month how the exam questions are coming and the candidates and everything. So there is no specific passing rate for a clinical exam. But just remember, it's same like any of your country's exam where you go for a lot of students go for exam, but few passes the exam. But if you do everything that we are saying, you will pass the exam. Okay, so that's the main thing. It's not like it's impossible to do. You don't get mail from AMC to enroll for exam, Dr. Shweta. You will need to keep an eye on the AMC website when the October and November exam date will be opened. Okay. So currently, I don't think still there is a date for that, but definitely go to the amc.org.au and find out like when it is going to be opened. Okay. They don't send you mail for that. It's not true. So for a clinical exam, there is no specific month. Like it's just totally luck. That if you know some cases and that's coming in the exam, that means you're lucky. If your exam question is hard, then you are unlucky. Okay. Now the thing is that if you prepare well, the no questions is hard. Once you get a format in your head, even if it is a new case, you can pass that case. It's all about doing a lot of role play and getting an idea about each case that is important for exam. Okay. All right, everyone. So I hope that you have learned things from this group and you can utilize that to pass your exam. And definitely most of you are already enrolled in the course. So we will see you on 27. Okay? Thank you all. Have a good night. Take care.